So, all right, welcome everyone. My name is Dr. Wesley Sanders, one of the psychologists here at Home Base. I'm glad to present Dr. Lipov today for our grand round. Dr. Lipov is a board-certified physician in anesthesiology and pain and the chief medical officer at the Stellate Center. He's the founder of Erase PTSD Now and author of The Invisible Machine, The Startling Truth About Trauma and the Scientific Breakthrough That Can Transform Your Life. In 2006, he pioneered the use of stellate ganglion block for the treatment of post-traumatic stress disorder, a procedure that was initially approved by the US FDA in the 1920s to treat certain types of pain and circulation disorders. Today, thousands of Dr. Lipov's procedures are being done each year among special forces and the military at Fort Bragg alone. Please join me in welcoming Dr. Lipov and his presentation for today's grand rounds at Home Base. Thank you.
Thank you for having me. Thank you very much. Well, it's an amazing place to be. I absolutely love working with veterans and special forces and active duty and their families. So what I'm hoping at the end of this is people to learn some of the new places where we can apply it and some of the data that's coming out actually. I do have a special thanks to Glenn Greenberg and Linda Avesta Foundation. A lot of those research and publication we were able to do are only thanks to their work. And especially there's a major study being done at NYU right now. And without their support, that wouldn't happen. I think that study will really move things along pretty far very shortly. Next slide, please. So the learning objective is to gain understanding the role of autonomic nervous system. I am pretty self-taught on autonomic nervous system. If you look at autonomic nervous system, people have not really been looking at it in detail since the 20s. There's a lot of interesting applications of that. So stellate ganglion block, obviously I know a fair amount about. It's interesting what other sympathetic system can do. It affects immune system in very interesting ways. Also, other psychiatric implications for stellate ganglion block. Some of the neuroscience mechanistics have been very interesting. The age reversal using stellate ganglion block, I think, is another area that's starting to come along now. Also, SOF method, which is ketamine and SGB combination to have synergistic improvement. Some of the things we talked about. We'll also talk about animal models. Anyway, with that, moving on. So point of intersection and mental disorders, autonomic nervous system. I think this is an interesting article just to see that people are starting to talk about it more and more. But the question is, what can you do about it, right? So I'm an invasivist. I stick needles into people. So there's a decent amount of things I can do about sympathetic nervous system. Next slide, please. So as a prelude, so there are there's a couple of ways to modulate sympathetic nervous system. One is by oral medications. Another one is invasive procedures. So alpha-2 presynaptic agonists such as clonidine has been used for quite a while, and alpha-1 blocking agents such as prazosin has been used. The good thing about those agents, they do penetrate blood-brain barrier, and they can affect nucleus ceruleus, which is the seat of sympathetics. Next slide, please. So this is just a basic overview of what clonidine does. So alpha-2 agonist, actually when you activate alpha-2 receptor, it's suppressed sympathetic nervous system, is useful to enhance sympathetic modulation. It helps people sleep. Unfortunately, if you take it for a long period of time, you can have withdrawal symptoms. But sometimes we add that together with procedures we do to kind of even it out. And I've seen it used in children, sometimes very effectively, sometimes not so effectively. Next slide, please. It's interesting that adrenergic targets have been evaluated for schizophrenia, which most people don't think about schizophrenia as norepinephrine-related disorder. But it's kind of interesting that, at least from my perspective, since I'm not really taught in psychiatry, like I was talking to Dr. Insel, who is used to be head of NIMH, and he said, "How do you come up with those ideas?" I said, "Well, I'm not burdened by knowledge. I didn't know anything about psychiatry." So I look at it from a little different perspective. But I think adrenergic targets will become more and more important in all type of psychiatric conditions. Next slide, please. So again, clonidine has been used for PTSD. That's pretty straightforward. And also, if you look at the reference below, they talked about clonidine used in borderline personality. Because there seemed to be a tension produced in schizophrenia and borderline personality that can be reduced with clonidine, which is kind of an interesting approach. So if you haven't tried it, it may be something to look at. Next slide, please. So this is something I know quite a bit about. So stellate ganglion block has been used since 1926. The first time I personally did one was 1987. So we used structures and stick a needle and hope for the best. It still works quite well. At least used to work quite well. Nowadays we do fluoroscopic guidance, or now the next thing is ultrasound guidance. Next step, please. So this is what the structures look like on ultrasound. With good ultrasound, you can see pretty much everything you need to see. Thyroid is here, carotid is here, anterior tubercle is here, longus colli muscle is here, sympathetic chain lives about there. So the great thing about ultrasound is you can see the needle real time. You're not exposing yourself for X-ray or the patient, but also you can see the blood vessels. There's a lot of very interesting anatomy that could be atypical, and injecting into blood vessel is not a good plan. If you inject 0.5 cc's of local anesthetic into a blood vessel, people have a seizure. So you have to be very careful, and that's why the only people that should be doing it are trained. There are some people getting on the bandwagon who are not trained, and I'm very much opposed to that. So this is when you do a sympathetic block, this is what happens. So you have Horner syndrome, which is droopy eyeball, meiosis, and redness of the cornea. People say this is a side effect. This is not a side effect. You want to see that. In fact, if you do not see that, it means you missed. So when somebody says, well, my eye was droopy, oh my God, it's like, it means they hit the right spot. That's a good thing. Next, please. So risks of adverse complication following SGB. The only time it actually was studied in detail was 1992. This is before X-ray guidance, before ultrasound guidance. This was in Germany. They did 45,000 blocks. There was no fatalities. They had pneumothorax, and they had a few convulsions. They'll also have high subarachnoid block in 6 cases. Keep in mind, this was done blind. So nowadays it should be much lower number. But the great thing about this procedure, if you have a decent or well-trained practitioner, those complications are definitely related to your skill set. So we do C6 block typically as opposed to C7. Classic description of stellate ganglion block is C7, which is right next to the lung. So moving in C6 makes it safer. The vertebral artery is encased in bone at C6. At C7 it's exposed, so it's safer that way. But when people say, what are the risks? This is only big study. But it's considered safe procedure. It's still minimally invasive. Some of the people who do this procedure say it's not invasive. That's not a true statement. If you pierce the skin, it's invasive. It's that simple. Next, please. So this is a great summary. Johns Hopkins University put out historical use of stellate ganglion block for psychiatric conditions. So if you look at 1947, Cleveland Clinic published an article on bilateral stellate ganglion block, which we could talk about bilateral versus unilateral, for treating depression. So if you think about 1947, it's a while ago. And then they also used 1955, they found that it worked for psychosis. But interestingly enough, it really wasn't utilized at all until I started doing it in 2008 for PTSD. And one of the most common questions people ask me, how do you even stumble on this? I mean, how did that happen? So what happened was that I had a patient that had severe hot flashes. I treated her neck pain, sent her to my brother to take care of hot flash, who's an internist, and he couldn't get hot flashes under control. So he said, well, you do this procedure, stellate ganglion block, for sweating of the hands and burning of the hands. That kind of sound like hot flashes, just the hand. why don't you try Stellate, take away the hot flashes? I was like, it's not gonna work. He said, you don't know it's not gonna work. So we did it and it worked. And we published on it. I mean, we were getting really good results. And then Chicago Tribune wrote a pretty aggressive article saying that I was an idiot and that I didn't know what I was doing. And the main reason was that I didn't know the mechanistics. So they gave me a lot of encouragement to read about why would it work for hot flashes. So during my research, I came across a paper from Finland in 1999 where they did T2 clipping, which is basically putting the lung out of the way, clipping sympathetic chain, and the hand sweats went away, but then also PTSD went away. So if you look at the anatomy, and I have some anatomical slides later, T2 ganglion is the highest ganglion in the thoracic spine to have sympathetic fibers come out of it. Then becomes stellate, and then goes to the brain. So that's all, took a little time to figure out. But once you understand that, I called up my brother and I said, send me a PTSD patient. And we treated him, and he was on his way to be admitted in psychiatric admission because he was abused, whatever. And he had a great response. And that's how this all started. Kind of weird, but that's how it is. Next, please. So this is just early history of stellate ganglion block. 2008 is the first time I've done one. Then there was another report by me and Dr. Mulvaney, who was ex-SEAL, and he was the first one to do it in the military institution. So he and I have been producing most of the papers since then. This is an interesting report by Dr. Alina, who's a psychiatrist, this paper in 2013. So it was a series of 4 people. One of those patients, his job was to drive dead bodies from Iraq to Germany. And then there was a couple of attacks on his convoy. It was absolute horror. He was trying to kill himself by drinking himself to death. So he had, I think, 4 or 5 psychiatric admissions. He was suicidal, blatantly suicidal for years. They did the stellate ganglion block. His PCL4 at that time dropped from 85 to 17, and his suicidal ideation went away, which is, I think it's pretty remarkable in one day. Next slide, please. So this is the latest article that was published in 2020 by Dr. Almstead. So this was based on N of 113. So it started at Fort Bragg, Lenchheim, Germany, and Tripler Hospital in Hawaii. And the idea was to do placebo-controlled stellate ganglion blocks, see if it worked. The problem with placebo, it's not possible to do the stellate. When you do the injection and you have an eye droop, the patient knows if there was an active substance or not. Nonetheless, so this is the best information we have right now. So this study basically showed that stellate ganglion block is twice as effective as placebo in military active duty personnel. So this was special forces, Green Berets, and people like that. There was an article before which I did not include because it's a terrible article, and that was written in the Navy. It was based on N of 42 people. They picked the people who were about to be discharged, and if they said they were better, they would lose $2,000 a month. So it's a highly prejudicial study. It was, the VA took a look at it and they said, that's not a study you want to be looking at because it's really was the wrong population. Plus it was poorly done, number of reasons, but people still throw that study there, but whatever. Next. So this is a kind of recent summary of 2021, and they talked about RCTs. So this article also talks about the study from the Navy. Again, I highly discourage that article. Like those who are interested in that, I'm happy to send you the official VA position on that study from 2017. What's interesting is some of the other things that we've seen. They have been reports of treating a schizophrenic patient from Japan with stellate, and the voices went away. So we'll talk about it in a second. Next, please. So one of the big things I'm interested in is primary and secondary PTSD. The reason being, my father had PTSD from World War II, and he gave it to my mother, who eventually took her life. So I had PTSD, she had PTSD, so I'm very interested in secondary PTSD. So currently, what we try to do, we're doing a project right now with Fort Campbell, where we're treating this fifth group, guys and the women, and sometimes I actually treat the children as well. So I look at PTSD as an infective agent. So if you treat STD in one partner and the other one still has it, it's going to come back. So if you look at this particular study that we published in 2023, so it was two couples. One of them was a Delta Force and his wife. Another one was exoneree from, he was falsely accused and placed in jail for 9 years. And after he came back, he had horrible PTSD. So everybody there had severe PTSD, but they all had good response. So I'm trying to get that. So that's one of the things I was excited to talk to Homebase about, is potentially either collaborate or your organization can think more about primary and secondary PTSD. Like I gave Grand Rounds in Bragg when it was still called Bragg. And I said, you know, are you guys treating the virus? Like, well, we don't have the capacity to do it. So I think there is having capacity and wanting to do is two different things. Because if you don't take care of the families, the war fighters are not going to be particularly effective and they'll have other problems. Next, please. So this is one gentleman. This was the first special force guy that we treated with SOF method. SOF method, at least the way I define it, is 4 ketamines and stellate right side and left side. So it turns out there's a synergy between those two procedures. Now I'll show you the reason behind it. So this gentleman is very interesting. So he was sexually molested from, I think, 9 years old to 14 or something like that. Then he went to special forces and he served in Iraq. It was, you can imagine, complete mess. He has been homicidal and suicidal for about 30 years until we treated him. And he's doing great, actually. He gave TED Talk in Portland X, which was amazing. Anyway, next slide, please. So here's the mechanistics, which is something to think about. So I did a weekend special forces training, they called it, which was 4 days of blowing up stuff and using big caliber machine guns. So we took down the doors, we did breaching. And I told the instructor, I said, hey, my head is like spinning. I go, that's like, you're a complete wuss. We use C4, this was just gunpowder. And so by the time you're out of training special forces, everybody has BTBI, more or less. So BTBI makes PTSD worse for multiple reasons. People here know more about than I do, I'm sure. But PFC, prefrontal cortex, will be affected by BTBI, and you need prefrontal cortex to suppress amygdala function. It is part of the mechanistics. Anyway, so if you look at what ketamine does for TBI, it increases new nerve growth. So it increases hippocampal cell function and reduces interleukin-6, which is inflammatory factor, of course. But it also activates BAX gene, which produces BAX protein, which produces apoptosis, which is actually chewing up hippocampus. And it also leads to sympathetic sprouting. Sympathetic sprouting, I believe, is a big part of what's causing PTSD. So if you take CSF fluid in a military person with PTSD, their norepinephrine levels will probably be twice as high as opposed to without PTSD. So that's pretty demonstrated. So if you look at ketamine, again, it promotes nerve growth, which is great. But sympathetic sprouting is a problem. But if you do stellate, it reduces sympathetic growth. It actually produces sprouting, and we'll talk about that. But it also reduces BX gene. So apoptosis of hippocampus is not as compromised, which is, I think it'd be great. Keep in mind, hippocampus has inhibitory pathways to the amygdala. So you want to keep hippocampus as well functioned as possible. A, memory, B, suppression of amygdala. Next slide, please. So we followed this guy 1 more year. So this has been 2 years this is just coming out shortly, but this is now online. So now it's been 720 days. If you look at his depression scale, start 31, he's at 1 right now. His PCL, I'm not sure why it's not there, but I think it's around 10. And the rest of those measures, if you think about it, that's significant. So he had one SOF method 2 years out, and this is where he's at. So to me, if you have people with BTBI, which is probably a third of the people coming back from Afghanistan and Iraq, this is what you want to think about. It takes more time, but it's well worth it, because if you look at current therapeutics with BTBI, they can definitely need help. Next slide, please. This was an article written by Jim Lynch, who's ex-Delta medic or doctor, or both. He is, so he wrote an article about reduction of anxiety by half, which is kind of makes sense. Next. So suicidal ideation is something I've particularly been interested in because of my mother. But if you look at the article we published, this was 2024. So overall, there was a 43.8% reduction of suicidal ideation based on N of 254. That's a pretty decent number. The cool thing about Stellate, it works rapidly. The compliance is really high, and it's fast. Because if somebody comes in, they have a needle in their neck, it's not that big of a deal. You do one side and another side, and hopefully you can reduce suicidal ideation, which is consistent with Dr. Lena's report, if you think about it, from 2013. Next slide. So other indications. Oh, yeah, that's it. Next. Here we go. So this was a really interesting case from my perspective. So this was published in 2002. This was just a very brief case report. So this was a gentleman who was schizophrenic. He had nasty voices. He gets kicked off a horse, fractures his shoulder, left side. And then he got first stellate ganglion block. His voices, which were nasty, became pleasant. And after the third block, they went away, which is interesting. But part of the reason I believe it happens because schizophrenia is partly at least amygdala responsible. You know more about than I do, but that's at least my understanding. And norepinephrine definitely has a part of schizophrenia function. Next, please. So the other part that's interesting, in fact, I was reading an article today that the immune system leads to depression. There is an immune component to it. So I wrote an article about stellate ganglion effect on immune function, which doesn't make sense if you think of it like, why would that possibly do it? I'll show you an interesting mechanism. But what's interesting, historically, the first time stellate was used was for asthma in France in the 20s, 1920s, no, 2020s. So there have been signs that interleukin-6 can drop. So one of the interesting articles was written in China where they looked at people who had TBI, not BTBI by car accidents. Half of them received stellate right after within 24 hours of TBI. The other half did not. And they followed them as far as TBI outcome and as far as interleukin-6. They measured 6 was primary focus. What they found is that right after the next day, I believe, after the block, interleukin-6 dropped significantly, while it didn't happen in controls. But long-term, TBI symptoms were significantly reduced in people with stellate. So when I was in Fort Bragg, I went to the Intrepid Center and I said, I think they have 100,000 jumps a year in that facility, which is a lot, and they have a lot of TBI. So my suggestion is to try to do a study trying to do stellate within 24 hours of TBI. So if you have a little more resources than I do, just a bit, I think it'd be a great thing to do because once people have TBI, this whole cascade starts, which is hard to reverse. But if you can do it within 24 hours, it's great. And compliance is high, right? Again, it's not that big of a deal. Most people, at least in special forces, I mean, I work with SOF from US and Canada. most of them already are kind of very on board with stellates, which is a good thing, in my opinion. So this is, I love neurotracings. Thank you. You read my mind. So the way they do it is you put retrorabies virus on, which is labeled, and then they go looking at different, where the connections occur. So it turns out if you put retrorabies into stellate ganglion, there is a direct connection to the spleen, bone marrow, and the thymus. If you think about it, that's most of the immune system. So you can see how that would affect it. So PTSD with stress doesn't really reduce or increase the immune system. It dysregulates it. So it's all over the place. You want it to have stabilized and you want it functioning better. But there have been a number of case reports where immune system were corrected using stellate. For example, ulcerative colitis, typically considered an autoimmune disease, have been treated successfully with stellate. They were able to demonstrate interleukin-6 reduction and symptomatology reduction, which, unless you think about this, makes absolutely no sense. Because you think you should do a ciliary plexus ganglion block, which I know how to do, but that's in the belly. But I think the problem starts at the neck and central. There's a central effect because locus ceruleus controls all the sympathetics, which is in the brain. Next. So schizophrenia, there is a relationship between interleukins and schizophrenia. So part of the effect of stellate may be directly in the immune system. I don't know. But that's one of the things you want to think about. We've treated a couple of schizoaffective disorders, and they seem to have response. But I haven't really published on that. It's not really a population I'm very comfortable working with. It's a complex population, shall we say. Next, please. We had a patient, this was a case report we published this year. So this gentleman was abused in Mexico. He came in and he had severe PTSD. We treated PTSD. He called us back 3 months later. He said, I didn't tell anybody, but I've been bulimic since I've been in my 20s, and he's in his 40s. All the symptoms went away, which is like interesting. Point is, there is a lot of odd little indications you can use. Besides PTSD, anxiety is pretty clear. I think schizophrenia will probably have some of it, but we'll see how it goes. Next, please. So one of the new amazing frontiers is biological aging and epigenetic clock. So I'm very much interested. I'm 66 years old. I'm doing evaluations for me. But there is some new literature that's coming out, and we've been working with UCLA using epigenetic clocks to see what is the aging and can you reverse it. So epigenetic clocks, the most accurate one currently is called GrimAge. It was developed by Dr. Harwath from UCLA. Next slide. So this is just definition of biological age. So there's a chronological age and biological age. So I had it done for me, for example. So my chronological age is 66, my biological age is 55. And I do whatever I possibly can to live longer. I'd like to operate into my 90s. But the point is, you want to think about that, and we're going to look at what the psychiatric conditions actually do to you biologically. So this is just the base indication that can show you. This is the GrimAge right here. So the bigger the number, the worse it is. So it's more acceleration. So PTSD cases, you can see, are higher than regular controls. And if you look at combat controls versus combat personnel with PTSD, you can see they're older biologically. So it is well known that people with PTSD, the chance of heart attacks is twice as high. So that's part of the explanation what you're seeing here. Next slide, please. So this is where hopefully we'll be publishing this relatively soon. So that was a study of N of 20. We've had double of the time getting data from those guys. So we got baseline epigenetic markers, and then we followed them out. So some have been compliant, some have not, but this is the best data we have to date, what Stellate actually does to biological aging. So you can see some of the reversal happening. Is that the cleanest data? No, but that's a beginning. Next, please. Interestingly enough, a couple of days ago, this was just released, 2025. So if you look what they said, molecular links between coronary heart disease and cognitive impairment. But what's interesting here, the stellate has been shown, and they talk about what is the mechanism of reversal of aging. So they believe it activates PI3K and AKT pathway, upregulating anti-apoptotic genes. So people are starting to look at that, as my point. And again, they're looking at it's a new term, a lot of new terms. Inflamm and imaging. So the more inflammation, the faster you age, which makes sense. But we do know that stellate affects immune system. So that's not a big leap to think that you can knock down this infla aging. Next slide, please. So, so this just talks about the epigenetic modifiers and how it modulates P1, 3K, and AKT. Most of the stuff came out of cancer literature. BX gene also is from cancer literature, but if you look at those genes, how they're working in aging, they seems to be working in that space. Next slide, please. Next slide. So this has been one of the big things that's like the reason people didn't want anything to do with stellate for hot flashes was you don't know the mechanistics. So this is the only complete study that was very brief. This was N of 8. Dr. Alkire did it and published in 2015. So they did PET scans before and after stellate on the most severe PTSD patient they could find. This was Long Beach, California. And they demonstrated right side amygdala deactivation, which is consistent with my theory. There's a big study being done, which I'm going to talk about at the end, in NYU. But I think once it comes out, it's going to be a big deal. Because there's FMR, we got all the trimmings there. We got functional MRI, we got CAPS, we got everything done there. Next. So this was a great study that kind of helped me understand what everything was. This was published in 2001. So basically, there was a retrograde study using the injected pseudorabies virus into stellate ganglion. They wanted to see what the connections were in the brain. And the connections that was pretty heavy was amygdala and insular cortex. So you can see why manipulation of stellate can do something to the amygdala. Next. So this is just some markings from there. Next. So if you're interested, those are some of the pictures from there. Those who are really into neurosciences kind of understand it to a certain extent, but not like the real neuroscientists. Next. So this is from my original theory 2009, where I was trying to understand why would stellate ganglion block work for pain, PTSD, and hot flashes. So I was trying to comment the commonality. So the commonality, next slide, please, is that NGF or BNGF is involved in all of them. If BNGF goes up, if you take BNGF and inject inside the rat brain, the fibers which is most sensitive to that growth, to that substance, is sympathetic fibers. So once you develop more sympathetic fibers, there's more norepinephrine. So as long as that's maintained, it becomes a problem. So the thinking is that BNGF or NGF gets transmitted to stellate ganglion here. And this sprouting is NGF dependent. So if you put local anesthetic in, it seems to reduce BNGF or NGF levels. And that leads to pruning, which is removal of reduction. So part of the big problem I'm trying to understand is why would a block that lasts 8 hours last for years? So I think there is a actually change in neurological structures, and that's why it can last. Next slide, please. So hopefully that's what happens. Calm person, no hot flashes. Next slide, please. So kind of one of the innovations for stellate has been doing a 2-level block. So C3 block and C6 block actually. So the history of that was kind of interesting. So I had a sniper who was a patient of mine for back pain. He came in and he was blatantly suicidal. I said, I'm going to kill myself. I said, let me put you in the hospital. He said, no, I don't want to. Anyway, so I did the block on him. I did a C6. And he's sitting there 45 minutes later, and he still says, I'm going to kill myself. And I was kind of pretty nervous at that point. So before I got into the PTSD work, I was lecturing in Norway, and I learned how to do C3 block. So I took him back and I did C3 block. And 5 minutes later, he was fine. He said, I'm not suicidal. Thank you very much. We followed him 5 years. He was fine. So I was trying to understand why would that happen? Because the way I was always trained is when you do CC block, it spreads everywhere. It's called the field block, but I don't think it's quite accurate. Next, please. So the explanation came actually from Dr. Moore, Stellate ganglion block. He wrote in the book 1951. So I'll show you a better picture of that. Next block, next. Yes. So basically, I think what happens is nucleus ceruleus, sympathetic fibers, preganglionic fibers leave nucleus ceruleus, go into stellate ganglion. So half of them here, go through vertebral artery and go to the amygdala right here in one spot of it, let's say. The other half goes up to superior cervical ganglion, goes to a different part of the brain, because the sympathetic fibers follow the vessel. So this is internal carotid right here. This is vertebral artery. So when I was doing just stellate ganglion block, I don't think I was hitting those fibers as much. So he needed more of a reset or reduction of those sympathetic fibers. I know this is kind of weird anatomy. Certainly as a pain fellow and pain attending, we've never really thought about it, because most people think of like CRPS, pain in the arm. We're talking about downstream effect always. Only recently people started thinking about central effect. But think about the cycle that can be set up. So there's trauma, there's activation of norepinephrine or nucleus ceruleus, but then you can go back, amygdala is activated again, and now amygdala activates nucleus ceruleus. So it could be a vicious cycle where people have really severe norepinephrine levels, and it could lead to a lot of sympathetic overdrive and a lot of what you see clinically. You can't sleep, hypervigilance, and so on. Next slide. So I had opportunity to do Stellate on a couple of dogs. You think about dogs PTSD. Turns out there's a lot of literature on that. So military dogs, about 25% of military dogs coming back from Iraq have PTSD. And then I actually did that. This was an accompanying dog who escaped and got stuck under a truck. And his symptoms, which is he couldn't sleep and he was very aggressive, were relieved. So I did the same thing on my kid's dog, and it seems to have worked also. So far I'm 2 for 2. Next, please. This is an interesting study done. Okay, this NYU study. This is what's being done right now. So they're halfway through it right now. So they should be publishing something relatively soon, like within a couple of months. And if you want to look up the clinical trial, numbers right there. But what's interesting is they found that, yes, stellate ganglion block is a lot better than placebo. What I'm waiting for them is that what does the FMR show? Because the hope is that amygdala deactivation will happen. The same thing Dr. Alkire seen, only on a bigger number. So N of the study is 150. But there's going to be the one presenting that. I just helped design it. I certainly wasn't part of it. Next, please. That's it.
Thank you. We actually have some time for questions. Would you mind?
No, please. That's why I'm here.
Online, you're welcome to just come off mute if you want to ask a question. You can also message in the chat, and we'll keep an eye on any posts there. But yes, please go ahead and feel free, and folks in the room as well, if you have questions too.
Well, people are getting the thoughts. Exciting presentation. Thank you.
Thank you.
Can you talk a little bit about stellate ganglion block followed by some kind of treatment for PTSD?
You mean psychotherapy?
Psychotherapy versus stellate ganglion block alone.
Oh, absolutely. So actually, we're writing a paper about that. You know, my wife always says, like, you know, whenever I ask anything, it's like, I write a paper on it. Come on now. So we have a clinic. We have a couple of clinics in Australia. So there was a psychiatrist there that has been working with a patient. I'm getting to the answer. He was working in transportation. So his job, as he describes it, is taking dead bodies out of highways, basically picking up years. He became sad and depressed, and this like from the fires. Couldn't really make much progress. And then he had stellate ganglion block. And the next month following that, he had tremendous progress because he was able to calm down and all of that. So the bottom line is, I think Stellate is not designed to be standalone by any measure. It's meant to have appropriate psychological therapeutics following that. So one I personally have a problem with is exposure therapy. Because the reason being, again, I'm not a psychiatrist, but I've met a lot of soldiers or military personnel, warfighters, who really have tried to go through it and they just cannot do it. But I think CBT or things like that becomes much more effective at Stellate. So it opens them up and they don't have overreactivity. And it's not just military. So yes, I would highly suggest doing appropriate. So to me, an ideal therapeutic is you identify the people who are sympathetically overactive, and you can do it in PCL. Those are the ones you should try stellate ganglion block early, and then do an appropriate therapy afterwards. I also recommend meditation, physical activity, as well as appropriate psychological support. Absolutely. I think that's huge.
You don't regulate the biology, and then the person can use this calmer state to
correct. The other thing we found, in fact, what's interesting, so if I may step back for a second. So the paper by Dr. Mulvaney. So this was written about special forces guys who were in Iraq War, won, and they had a lot of kills. So one of them fell asleep after stellate ganglion block and got into pretty severe car accident. The reason that happened is because if you think about it, so the way, in fact, I have an illustration like that somewhere. So if you think about PTSD, it's pushing down the gas pedal. So the engine is revving. The medications you're taking is brake. So you both are together. If you take the foot off the gas pedal, now the brake dominates, and that's why he fell asleep. So we're able to get patients off significantly of atypical antipsychotics, benzos, whatever. They can participate in psychotherapy even more effectively. Not only do they get wrapped up, but they also are not as sleepy, because the average number of medications currently given in average VA is significant.
Yeah, makes sense.
I have a question.
Yes, sir.
Oh, hi, Dr. Lipov. Thank you so much. An incredible talk, and thanks for all your work. I'm a physiatrist or a rehabilitation doc, and I'm very fascinated with, from a brain injury perspective, you've mentioned blast TBI, and I'm wondering about the thoughts on, you know, why do we think there's some sort of, well, I should ask the question a different way. Is there a response to SGB in the blast injury folks that have PTSD that is different than the same level of PTSD with somebody that we think did not have any blast injury?
Let me just rephrase the question so I understand what you're asking,
yeah.
If you don't mind. So are you asking if you have a patient with BTBI, I assume that's a fair term, right?
Yes.
Blast traumatic brain injury, and PTSD. So as opposed to somebody did not have BTBI and just have PTSD by itself? Is that the question?
Correct. Correct.
So the answer, I think, is straightforward. I think BTBI definitely makes PTSD worse because you're losing prefrontal cortex. Also, you're losing hippocampus. Because when you shake the brain, I'm sure you know better than I do, when you shake the whole brain, you're affecting all the structures, of course. But PFC and hippocampus are the two structures that really suppress amygdala. They're designed to do that. Interestingly enough, there was the first guy we ever treated for PTSD. He was shot down twice in Iraq. He was knocked out for an hour both times, had blood in the ears. Then he was patrolling the streets. He shot a kid, 10-year-old kid, line of duty because he had an explosive belt on him. And we were able to get FMR before and after. So we were able to demonstrate amygdala deactivation and activation of hippocampus. So I think Stellate does have impact on BTBI and TBI. So I do believe somebody who has BTBI makes PTSD worse. Again, because you're missing the inhibitory structures.
Thank you. Yeah.
Of course.
I appreciate it.
Yes, sir.
Sure. Any special precautions in patients that also have hypoarousal or dissociative features associated with PTSD?
That's a tremendous question. It may not, well, maybe is my answer. So I think part of the question is what's causing that. I think if you think about, you have, I spend a lot of time with Dr. Porges, and he is into polyvagal theory. That's his thing. So the whole concept of vagal tone, so sympathetic tone activation happens before freeze, right? Freeze is the last piece of response. So I think if the vagus is so overactive, that's why they're almost frozen. We have seen people get significantly better after Stellate, and some people made no difference. One thing we did, I'll give you an example on that patient, it's kind of interesting, so which is similar to your question. So the gentleman had, he was in Vietnam, he had a head injury, had PTSD for 50 years. So we did the block, and he cried like a baby for like half an hour. And I was like, I don't know what happened to that man. So he said, I got access to my emotions after the block. So a lot of those people who got shut down, they have no emotions whatsoever. So some of them do get better. I think success rate in that space, like our success rate is 70 to 80. That's probably 50, 60, because I think their parasympathetic system is trying to do all it can, is trying to do the dive reflex, and that's a hard problem to solve. Cannot be done, but just not as effectively. Of course. Yes, ma'am.
Denise asks, says, thank you for your wonderful presentation. Do you typically see results after one procedure block, or do some patients need more than one? How do you determine the difference?
Oh, okay. So the question is, does it take one procedure or multiple procedures? Is that the question? Pretty much. So first of all, we didn't even talk about laterality yet. So we always start the right side. The reason we start the right side is because if you look at a number of studies, they show that the right-sided sympathetic dominance. So we do right side block, and if the patient feels a lot better, we stop. We never do bilateral blocks the same day. The reason being, when you do the block, it depends on a practitioner, right? I've done about 5,000, somebody who's done 2 is a different technical skill set. But no matter who does it, there is a chance of hitting radiculolaryngeal nerve or numbing it up. If that happens, there are 2 vocal cords. One of them will go to the midline. If you do bilateral, same day, and both go to the midline, it becomes a surgical airway, which is not a good thing. I've done trachs 40 years ago, so I don't want to do that. But if we do the right side, let's say, people feel 3 things can happen. They feel great, then we're done. 2, they feel nothing, and we bring them back as soon as we can to do the other side. Or if they go, I'm not sure. I'm not sure means a failure to me. So out of the failures, right side failures, if you do the left side, then those patients, about 50 to 60% will have significant improvement. because there is two amygdalae, right? So if you only treat right side, sometimes the left side is what's causing the problem. That's why you may need it both.
So thank you.
And maybe just a follow-up in case I was misinterpreting her question, would you ever come back and do the procedure another time?
Oh, yeah.
After those 2 attempts at that point, no future procedures?
Well, it depends what happens. If people have no response and they had a good corners and they had right and left side, to me, that's a non-responder in this stuff. Some people will do multiple procedures. I think it's questionable therapy. I think it's like maybe. But there's the other question is, let's say we had a policeman in Chicago who had a great response. We did both sides. And then for a year, he was doing great. And then he had to kill someone in line of duty in Chicago streets, came back. So we did the right and left again, and he did great again. Also, we can do, let's say we had one author from Portland. So we did 3 stellates, each one would last about 3 months. So we brought him back and we did something called pulse radio frequency, which is an electrical way of making a longer response. So we had 2 of those and it's been working now for 10 years. So there's a way to make it. So if the question is if there's no response at all, I would say switch something else, ketamine, TMS, whatever. Also, if they have a very good response but doesn't last, there are other options.
Thank you.
Of course.
Any other questions? Okay, going once. All right, well, thank you all very much for attending. Thank you again so much for the fantastic.
Thank you. I hope it was
presentation
interesting.
today. Yeah. It's great
Different
to have
angle,
you.
right?
And this recording will be available on the Teams drive for those who are virtual today.